we'll now request Dr. Shilpi Narnaware for her talk on recent trends in management of ROP.
Good afternoon, everyone. So we all know that ROP is increasing nowadays because of better NICU facilities, and it is a preventable cause of blindness in the children if timely intervened. So in the last few years, the treatment has been shifted from cryotherapy to the lasers, anti-VEGFs, and now vitrectomies. So why there is a shift? It is because of the ICROP third edition, which is recently added in 2021. With the advent of the improved imaging techniques and technologies, and specifically because of the paradigm shift from the laser therapy to the anti-VEGF therapies, and one most important thing is medico-legal aspects. First, the classification was given in 1984 and then revised in 1987. Further revision was done in 2005, where pre-plus and APROP was added in the classification, and the recent one is in 2021. It is done because to recognize the other patterns of the ROP, which is not seen in all regions of the world, and because of the innovations in the ophthalmic imaging and introduction of the anti-VEGF therapies. So what are the diagnostic modalities? Direct ophthalmoscopy is not advisable in cases of ROP, as it only detects either the zone 1 disease or when the baby presents in the advanced stage of stage 4 or 5. Indirect ophthalmoscopy is still the gold standard, but the limitation is that you need to do a scleral depression, which can cause sometimes the problems in the baby. Wide field imaging in the form of the RedCam or the Indian version, that is NeoRed, is coming up because you can document the disease, and especially for the medico-legal cases. It is not a model which is led by the ophthalmologist. In this, nurses are trained, and we can send the images to the ophthalmologist, and from the far areas, the babies can only be asked to reach the tertiary centers only if they are needing the treatment. So it is based on the objective versus the subjective interpretation. And yes, now we are seeing the surges in the medico-legal aspects and the gross negligence, and the compensations are in crores. Another one in the recent future will be the artificial intelligence. Now coming to the treatment options, cryotherapy, it is mostly outdated now because of the unfavorable results and many complications related to this treatment modality. Well, then come the red lasers, which was, I'll say it was a treatment which came after cryotherapy in the ROP cases, which was done only in the threshold ROP cases. After that come the green laser, which was introduced to the world by the PGI group of the India. So with this, there came the newer indications for the laser, because ETROP came because there were the unfavorable results seen in the 20% of the babies when we treat them in the threshold cases. But there was a urge that we should treat the patients in the pre-threshold stage so that the favorable outcomes should be increased. So with the ETROP, the favorable outcomes increased to around 87%, and the visual acuity was achieved in more than 20/40 in more than 80% of the babies. So these are the various types of type 1 ETROP, where the lasers are advisable in the pre-threshold stage also, while in the case of the type 2 ETROP, you can just follow up the babies. Another disease is the rush disease, or what we called as APROP, which still has an unfavorable outcome in more than 25% of the babies. Half zone diseases, when the vessels are not mature even beyond the macula, you can treat this disease in two strategies. One is two-step laser, that you have to do the laser in the first sitting up to the presumed arcades 3 disc diameter away from the macula, and subsequently you can laser the retina when once it matures outside the macula, or you can use anti-VEGFs then followed by the laser. Another is the hybrid ROP, in which there is a combination of the APROP and a staged ROP. In this also the lasers are indicated aggressively. Smoldering ROP, when a few clock hours, they doesn't regress, and it is usually treated to prevent the complications when the baby have achieved the age of 48 pma or gain the weight of 3500 grams. Additional indications are persistent avascular zones after the anti-VEGFs or recurrences which are seen. Now coming to the anti-VEGFs. The first trial was the BEAT ROP trial, in which the long-term side effects were not addressed. Similar was the case with the Rainbow trial. Even in that, the long-term side effects were not addressed. The absolute indications are the media haze, adjunctive to the lasers, pre-surgical, and in the rescue therapy when a trained ophthalmologist is not present to do the lasers. So in present scenario, the current indications are APROP, zone 1 disease, and in cases of half zone disease. There we should use the anti-VEGFs cautiously in cases of relatively advanced cases because of the problems of retinal breaks and the crunch phenomenon. Advantages, yes, we all know it has a wow effect and it induces less myopia. Refractive errors, yes, as I already said, it induces the less myopia, but it is seen that more cases of hypermetropia are seen with the use of the anti-VEGFs. So coming to the adverse events, it causes crunch phenomena and the systemic factors. Coming to neurodevelopment outcomes, there are mixed responses with the use of the anti-VEGF. Few studies are saying that it causes neurodevelopment delay, while others say that there is no neurodevelopment delay with the use of the anti-VEGFs. There are the many options, but we are still struggling about the doses, which dose is to be used, and what are the timing of the injections, but it is said that it should only be given in the phase 2 when there is a VEGF surge. And how much is the time period of the effect of any anti-VEGF? We don't know. So now coming to the regression, it refers to the disease involution, and there are different patterns seen with the spontaneous regression or after the treatment. The signs of the regression are seen early with the anti-VEGF therapy when compared to the laser photocoagulation. These are the signs of the regression, like you see the decrease in the plus disease or vascularization up to the peripheral vascular retina. So with the laser, you can see the dilatation of the pupil, retraction of the blood vessels, decrease in the dilatation and tortuosity of the blood vessels, flattening of the ridge, and regression of the disease. And this figure shows the regression of the disease after the use of the anti-VEGF. Reactivation, it is more commonly seen after anti-VEGFs compared to the laser therapy. Yes, it is also seen with the lasers, and in that cases you need to just do the fill-in lasers in cases of the recurrences. While with the anti-VEGF, the recurrence is seen more earlier than with the Eccentrics when compared to the Avastin. So signs of the reactivation are development of the
Shilpi,
new
will
line.
you conclude, please?
Yes, sir.
Thank you.
So this, the most important thing is that you need to document whether there is a regression, recurrence, or reactivation of the disease. So persistent avascular retina is seen more commonly after the anti-VEGF use. The other modalities are the FFA and the OCT, especially in the era of the anti-VEGF's use. So I think I should skip this.
Yeah, actually it's a little long. Just one small point I would want to know. In zone 2 diseases, are you still going ahead with lasers, or do you prefer anti-VEGFs over
So we
laser?
prefer lasers
Okay.
in zone 2 diseases.
But I think that is a point that lasers used to be a age-old treatment, but I think in zone 2 diseases, even lasers are working very well. Even aggressive ROPs which are in zone 2, especially in anterior zone 2, where you have aggressive ROP, that's why the terminology is now changed from
To AROP.
aggressive. Yeah, so lasers do work well, and patients may not need laser after anti-VEGF.
So, but we
So-
have seen that most of the cases, there is thinning of the blood vessels, and after a time there is a recurrence, and we need to do the lasers in maximum cases.
But usually
Yes,
if you
the
follow
amount
up,
of the
yeah.
laser done is less.
I agree, but 10 to 14 weeks you follow, then maybe people are even following up till 60 weeks. So we should not hurry with laser,
Yes, sir.
and we can maybe FFA, as you mentioned, the machine 3 Netra, these new machines which have come up. So FFA still has a role. So basically I wanted to emphasize that anti-VEGFs are taking over lasers these days.
Yes,
That
sir.
is what I wanted to.